Wonderful. So our last panel of the morning is on the challenges. So our last panel presented us the opportunities, and now we're going to hear a little bit about the challenges, but also how policy and standards, as has already been alluded to, may be helpful in that regard. So in this panel, we'll have 3 speakers again, each with about 8 minutes, and we'll do questions at the end. Our first speaker will be Dr. Abdou Niang, who is a nephrologist from Senegal. Suzanne Watnick is our second speaker from the University of Washington, who is the American Society of Nephrologists expert in policy and residence. And then our third speaker will be Fokko Wieringa from the Netherlands, who is already self-introduced as a technologist. So Dr. Niang, if you'll get us started.
Thank you, Katherine, for this kind introduction. I will talk about challenges to implement environmentally sustainable dialysis in low and middle income countries. No conflicts of interest to disclose. The 4 principles of sustainable health care include prevention, patient empowerment and self-care, lean service delivery, and use of low-carbon alternative as described by UK Sustainable Healthcare Framework. And 3 overarching strategies are to reduce demand, matching supply and demand, and reducing emissions. Learned services delivery is defined as the optimization of a service delivery with the goal of maximizing environmental sustainability. The dialysis supply chain is also of important environmental concern. Between 60 to 80% of the healthcare carbon footprint is contributed by the supply chain. And drug manufacturing and transportation are major generators of emissions, as described. In sub-Saharan Africa, most dialysis consumables are imported, including large quantity of 10-liter cans of acetate bicarbonates, which comes with both a financial and an environmental cost. And bundled orders, reducing packaging and using concentrate or powders instead of large volume canisters can all contribute to lower carbon emission. Calls for local manufacture of dialysis supply, staff and patient transportation are major contributors to HD emission in high-income countries, but have limited impact in low and middle-income countries. Clinicians and dialysis staff can be educated on efficient water usage, waste reduction, and energy conservation. Health authorities and dialysis providers must recognize the importance of integrating green practice into dialysis without compromising the quality of kidney care. Financial support and incentives may be required to support quality improvement projects and foster a culture of environmental responsibility. What about low-carbon alternative and innovation? Dialysis services are increasingly become available, also not equitably accessible in low and middle-income countries. The debate, PD versus HD, PD being performed at home and with a limited amount of fluid per day. It will be more sustainable than HD. However, some elements still to be clear. For example, Connor thinks that PD generated more waste than HD. And Professor Mohammed talked about the PD fluid manufacturing. It can be also an issue. A low carbon innovation in the dialysis space, which aim to provide more financially and environmentally affordable PD fluid manufacture. The development and testing of the system are going to support regulatory submission and subsequent approval for commercial distribution. Many innovations are simple and implementable in low and middle income countries, like LED lighting and variable speed motor pump can be considered to reduce power. As you know, in regulation policy, mandate green dialysis or link greenness to reimbursement are intervention possibly applied in the low and middle income countries. Some intervention like monitoring environmental impact, set standards for environmental benchmark may be implementable, but which need strengthening. What about clinical intervention? Reduce unnecessary drug prescription to prevent kidney failure, to incremental dialysis are possible to be applied in low and middle income countries. But other intervention like self-care dialysis, for example, some HD units where patient dialysis at home are available in some countries in Africa, but not at large scale. Home dialysis also is a great concern in our country and in low and middle countries, and it is not available everywhere. The non-clinical intervention like educate patients to separate waste for disposal, use reusable food and drink, water of reverse osmosis reduction is possible, like careful with priming volume to reduce dialysis flow also. But some intervention like recycle canisters, packaging, or for example, central dialysis, are some intervention which can implement in low and middle income countries, but it require equipment installation. For example, about the power, it is possible to reduce dialysis temperature. For example, to reduce electricity, it's need some measure and to strengthen some teams to implement this kind of intervention. What about waste? For example, in Africa, many waste are in the landfill. Incineration is possible, but it is not available everywhere. And recycle must be possible. And the dialysis reuse was practiced in some countries. And about technology, it is possible to optimize dialysis flow, the blood flow, online priming, to use standard by mode, and optimize disinfection protocol also, and many action targeting the dialysis, bicarbonate, acid concentrate, or telehealth are possible in low and middle income countries. The low water machine, like portable HD machine, may not be available now. What about smart building? Some smart building, as in Morocco, has been implemented, and I think it is possible, but some intervention which make climate resilient or insulations is possible, but especially if we have to build a new unit of HD. What about transportation? We can reduce packaging and pole transportation, bicycle stand. But for point-of-care PD fluid generation or locate dialysis unit near critical mass of patient, we need some planning or some machine to make it possible. Staff education is possible in low and middle income countries. In conclusion, all this intervention is possible, but sustainable and cost-effective intervention must be chosen. Thank you very much.
Thank you, Suzanne. Thanks. Wonderful. Well,
Well, thank you again. Really excited to be here amongst such an august audience. And I'm here to talk a little bit about the policy imperatives to drive environmentally sustainable dialysis. We've heard a lot from the audience in terms of how important it is to actually bridge the science that we're considering and the global imperative to the policymakers to make the case that we need to move forward. Here are my disclosures, and by way of objectives, I want to talk a little bit in these 8 minutes about how one would plan a policy brief to either bring to your regional governmental group, nationally, internationally, or to private industry to make the case to actually support this. You need to define the problem and the urgency. We've heard a lot about that already in the audience. I want to talk about how you'd promote key areas for intervention. Sharing global policy initiatives actually makes the case by explaining that you're not, you don't have to reinvent a wheel. Talking about the challenges, as Jenny just mentioned, in terms of implementing, and that actually talking about developing shovel-ready policy recommendations, which are critical. So the first 2 slides, I'm not going to go over all of these words because you heard a lot of this from the first several speakers in terms of defining the problem around water and energy consumption, waste generation, and carbon emissions, and then explaining to those policymakers why this is urgent, why does this matter, how CKD burden is growing, the climate change impacts, and how we do have an ethical responsibility to the planet, but at the same time, continuing to provide safe and effective, high-quality patient care. So on to our next objective in terms of promoting key areas for intervention. Any green dialysis journey, you have to incorporate not just the dialysis facility, but also the overarching organization and the healthcare system's buy-in before you even go to any regulatory body. And the patient has to be at the center of the discussion and change management. This is Matt Risher. He's a gentleman who actually was in the first dialysis facility that had the first COVID patient who died in the US. You can see potentially the fear and anxiety in his face, but he was also very involved with advocating for environmentally sustainable dialysis, and he worked with wearable and artificial kidney groups to try to improve the lot of the patients sitting potentially in a dialysis unit. So areas for key intervention, we talked about water management and energy efficiency, waste reduction, sustainable procurement, the R&D, which we'll go into in a little bit more, and education awareness. As Jenny and Katherine mentioned, the topic today is not about dialysis avoidance, but it is an important point to bring up to policymakers. I'm not going to go over every word on these slides, but these 7 areas, the first 3 on this slide, what are the policies that we should adopt for efficient RO systems? Regulations, a lot of the manufacturing regulations incorporate more than we need to in terms of how much water you need to rinse through items, how much saline you have to use. So it's important to go back and investigate. What are the building codes and the standards, the renewable energy resources to power a facility? Those can change to try to lower the energy footprint. And the regulations for reuse or recycling, again, where it's safe and feasible, you can think about how to recycle in a center. And the last of these 7 items, procuring, well, a government or a healthcare system actually can create policies to prioritize environmentally friendly products. So if they preferentially create contracts, and again, you can advocate for this with certain suppliers that are more environmentally friendly in terms of how they manufacture or how they dispose, this makes a difference. Life cycle assessments, we heard about those as well. Procuring funding is no small issue. We'll talk about that more in the next set of slides. And really, public-private partnerships at this point are important because public funding is really starting to not be as available as it once was. Education, awareness, not just for us as nephrologists, but for the patients, for the public, so that they can advocate for this. And we talked about dialysis avoidance as well. So again, to prove to people that you're trying to make this story that we need to act, make sure you share some of the global policy initiatives that are already out there. Again, the concept of not reinventing the wheel. We heard about the Green K initiative, and we're a member, as well as many other groups, not all of whom are listed there. Go to the website if you haven't, because the tools and the resources are plentiful. In the UK, you heard about the NHS net zero goal with sustainable kidney care commitments. The European Union Kidney Care, also heard a little bit about that. What about national guidelines? Does your country have national guidelines? Italian Society of Nephrology, the French Society of Nephrology, and the ASN is just launching an emergency partnership initiative around this. There are also sustainability prizes. So just last year, this was a public-private partnership in the US, over $7 million put forth to look for prizes to decrease water and power use in dialysis environments, both for PD and hemodialysis. And we were able to actually award that money and get some of these companies moving forward to do their work. And just this conference, advertising the output that we have will make a difference. Talk about challenges, however. Not everything is as rosy as you're hearing. Financial constraints are real. If you can't make the business case for what we're doing up front, it's going to be a concern. Again, governments don't always have money, so you need to find a champion. In the US, we have a Congressional Kidney Caucus, and we actually meet with these people on a regular basis in parliaments, in different governments around the country, or around the world. Make sure that you're meeting with your members. Find the champions who can advocate for this. Balancing these goals with patient care is really paramount. I mean, I was so compelled by Janelle's story, and I think that that kind of story really, again, can make the case to both public and private partners who can fund this. There's a lot of resistance to change and a lot of regulatory barriers, but again, you need to find the people who are going to champion outside of the nephrology realm. The data gaps are critical. If we have data to make clear what our story is, that we can make a difference, we may help to develop policies on behalf of these individuals who may be the champions to get funding. Global disparities, you just heard about the issues with low and middle income countries and the resources. Maybe some of the barriers are going to be greater, so how do we address those? And just the lack of education and awareness. How do we address that and develop programs to make people aware and educate them on this important concern? So the last of all of these issues with policies that can be shovel-ready, there are a number of actions, and this is not exhaustive, these 7 items on the side. So what are some granular examples of things that we can do? We're the champions that can bring this out. So national green dialysis strategies, let's give yourself a year and try to identify an expert group who can create a country's green dialysis policy if you don't have one already. Issue statements. We did this 2 years ago at the ASN, and a lot of people read it and get back to us asking questions. Incentivize the sustainable practices. Again, you've heard a number of great examples, but they're small and they're very local. So what if a parent organization, a large dialysis organization, for example, can be incented to do this? If there are tax breaks just in general for dialysis companies in a country, if you use a certain amount of energy that is less than you used before, maybe give them a tax break. Again, these are things that you can propose. Offsetting carbon footprints of meetings, we're starting to talk about this at ASN. Establishing clear regulations and standards, we heard that over on this side of the room. It is critical. Again, sometimes healthcare is local, so maybe you need to do this for a region or a nation, but how wonderful would it be if we can develop some international standards? Promoting collaboration and knowledge sharing, so how can you harness regional groups and meet again and again to develop this with the experts and include the providers, the patients, the governmental people who are making policies. Investing in research and development, again, who are you going to identify to allocate annual funds with these public-private partnerships, which is a potential way forward? Because again, your elected official may be there for 2 years. And if that person is there for 2 years and your business plan says we're going to recoup in 5 years, are they going to be a champion? Not as likely. So it might be the private industry that is going to see those investments recouped over the 5 to 10 years, and you can use them as champions. Integrating sustainability into quality work. So what are the quality metrics around decreased water use? And require metric reporting. Maybe you give bonuses or penalties to payment. And supporting low and middle income countries, which you already heard very eloquently just prior to me. So in conclusion, I think really we need to adopt comprehensive policies for green dialysis to mitigate the environmental impact of this life-saving therapy. I'm speaking to the choir, but that's not always the case for those of you who are going to go out and try to get support. Learning from best practice and global initiatives, supporting education and awareness, and future research can really help pave the way to make dialysis more sustainable. And collaborating, innovating, committing, there's no way to replace the constant meetings that you can have to get champions to argue for this. It's really key. And what I'll end with is this quote by David List, who's a professor of economics and served in the White House more than 20 years ago, but this quote is just from last month. I think everything we scientists do can be undermined in the eyes of the policymaker and the broader public. So we must understand how to use our own science to make better policies. Thank you.
Hear, hear. Great speakers. So how can a simple technologist improve on that? I'll do my best, at least to support it. So I'm going to introduce you 2 technologies that may help to reduce the eco-footprint of kidney replacement therapy. My disclosures are, I am not, unfortunately, a medical doctor or registered nurse. I'm just a medical technologist. So I think about technology that helps you as a tool. I am a co-inventor, but not the owner of several patents regarding chip-based hemodialysis filters and toxin reduction and so on, but okay, can't help it. I'm also a contracted technology advisor to Next Kidney. That needs to be disclosed. I have no financial interest in clear flux technologies, which also will be shown, but via the Kidney Care project with Karin helping, we will work with their technology at our hospital in UMC Utrecht. So I'm employed by IMEC. For 10% of my time, I also am helping UMC Utrecht as an assistant professor. Okay, plastics. We've been talking about plastics. Typically, what we do is we take fossil feedstock, so oil or gas, and we convert that using a lot of water and energy into medical products. That's how it's being done. And the highest up in the chain has the highest value of invested water, energy, transport, and so on. So a very big win, if you look upon it per component, per article, would be to reuse dialysis filters at the place where they are, because that might be interesting. And there's a lot of energy and effort being put into making those filters. The good news is I will show you a technology that can reuse this up to 40 times, which is FDA approved. So already FDA approved. Well, of course, we can also take things apart. So we collect the waste, as we've seen, and we sort the waste, as you've also seen, and then bring it back to technology partners that converted this plastic waste into recycled feedstock. So the same kind of feedstock, but from a recycled source. But then you need a mass balance certification trajectory. Good news, that's already there. So the international certified mass balance feedstock has been already put in place, which means that you might also use bio-based resources, like the grease from the guy that makes the French fries, or you grow plants and take care that you're not displacing food production with the plants that you grow for the oil production, but it can be done. And then you make the same kind of feedstock. So the molecules are identical. You enter them into the mass balance certification. And from there, you can then simply say, my product has 90% of reused or recycled or even bio-sustainable feedstock. That helps. Okay. Oh, sorry, I went the wrong way. Note, it was mentioned before that making plastics also costs water. Not a little bit, a lot. Good, clean water. And of course, making plastics takes a lot of energy. You have to make it, you have to sterilize it, you have to transport it. 3 times energy. Okay. So I just said, and the highest value is in the highest place in the chain. And one of those components is the dialyzer, if you're talking about hemodialysis. And there has been, and that is still available, an FDA-certified dialyzer reprocessing, which already exists. So you don't have to develop it, it's there. Why don't we use it then? Well, because this machine can, on the spot, help to up to 40 times reprocess your dialyzers. Well, it uses an active flow, active foam. Anybody that cleans the car with the active foam knows how that's... There's always a better cleaning if you have a fluid and a gas. If you have a foamy mixture, you clean much more efficient than if you have only one of those components. And this is certified, it's there. I don't have any stocks in it, I don't sell the stuff, but we're using it in our kidney care project because we think that's good. Interestingly enough, the same dialyzers, from a technological point of view, coming from the same production line, can be labeled in 2 ways. One, suitable for reprocessing. The other label is single use only. It's the same dialyzer. It's just different stamp. Interesting, isn't it? And that is because there's different regulations, as we talked about today. So talking about your policymakers about the regulation is a bit stupid to prohibit to reprocess a dialyzer just because the stamp is different. If the thing technologically is the same thing, it doesn't make sense. So we have to communicate that clearly. Now, there has been a cost analysis done, and we have only 8 minutes, and I'm probably already beyond that. 1 dialysis session with the reuse, taken into account, of course, that it will be reused, and 1 dialysis session without reuse. You see the CO2 there. It's quite a clear difference. So this is harvesting the fact that it's highest up in the chain, most invested water, energy, and feedstock, sterility, but you have to use the filter on the same patient, only on the same patient. So that takes a bit of a barcode and so on. For home dialysis, that's super good news because there's hardly, I don't know any household where 2 patients are dialyzing in the same household, but even if so, it would be doable. Okay, and these are the researchers doing this work, also with Kidney Care together, and they're doing a wonderful job. I don't have time to go into the details. Now, here's an engineer's view on hemodialysis. This is an engineer block diagram, simplified. What we have at the present is single-pass machines. We take a huge amount of water, we have to purify it, then we have to mix it with the salts, and then we have to heat it up in a big reservoir, and we pump it through the filter 1 time, and we throw it away. That's what we do nowadays. That's a bit of a pity because we lose a lot of water and a lot of heat that we pumped into that water into the drain. Now, you can have a heat exchanger and you can gain a bit of heat back, but still, it's a lot of waste. Now, this is coming up now, and this is dialysate regeneration for hemodialysis. It has already been shown first in human in patients, and it works. And it's now going to be a clinical trial started to have 1,000 treatments that are required for the CE marking. So this will be CE marked pretty soon in Europe. And if we don't get too much tariffs, we might even export it to the United States. Who knows? Anyhow, just a comparison. Single pass, about 120 liters of dialysate, average. And here, 5 liters, 4.5, 5 liters. That's a big difference. But also in electricity, because the heat that you injected in the dialysate, it's only the radiative loss to the environment, but the heat remains. So you only need a very low power to heat it, which means you can take this machine to any wall socket outlet, and you don't need a grounded wall socket outlet. You can do any motel. If you have 300 watts, that's all you need. Any motel, any camping. Hygiene will be limiting, not electrical power. And no drain needed, because you can just simply add empty 5 liters. Okay, dialysate regeneration, great. And I'm showing also Victor Goura's work, also using dialysate regeneration with the wearable. He's working on a version 3, which is much more ergonomic, and the next kidney machine, which you see there. Now, it's important to look upon the machine there. The left side, the left half of the machine is the blood module. The right side half of the machine is the dialysate module. Okay, well, nice. Why is this important? Because suppose that we implant the filter, and this is not fiction, this is science. I'm not the only one promoting this. Also, Shuvo Roy and Bill Fazell in the US have their kidney project promoting to implant the dialysate filter. Hey, I don't need a blood pump. We already got a blood pump built in. You do not? You have a blood pump inside you. And it's very efficient. That is really interesting because we lose the blood circuit. We lose the disposable blood circuit. We lose the needles, patients would say, and that's more important to them. And we can then have half of the machine that I just showed you and use it for the regeneration of the dialysate. No needles? Even half the size of the machine I previously showed you already fits in a carry-on suitcase for the airplane. This one would halve a carry-on suitcase for the airplane. Even EasyJet might take it along. Wow! Sorry, EasyJet, couldn't resist. So you would have more or less a PD-like experience as a patient. You'd have still 2 connectors. If you don't use them, you just short-circuit them and you go wherever you want. Nocturnal dialysis would be much more easy. Nocturnal hemodialysis, because the risk of losing the needle, the return needle, is gone. And that is something to think about. If we could have nocturnal hemodialysis much more easy, that would help us. And it's greener. We lose the complete blood circuit externally disposable, which means a lot of less waste. But of course, that filter has to go on then for at least 2, but preferably 5 years. Otherwise, the surgery would be too much buried. So that's the bottleneck. But if we make that, we get a completely new view on a technology-based kidney replacement therapy. One step further, also much further in time, will be that we will have a bioreactor added. Because all hemodialysis and NPD at the moment in the world is only replacing the glomerulus function, the filter, not the tubulus. But we know from Mike Oldfield with tubular bells that the tubulus is very important as well. In fact, the tubulus gives us a chance to live on the land because we recuperate 90–95% of the water. So this is further away in future. But the interesting thing is it's modular. Let me go quickly back. This module that you see there for the implantable filter already exists. So we take a building block and we reuse it. And if we take this one here, we see we reuse the building block of the implantable hemofilter, and we add a new one, the bioreactor. So if we make a modular approach, we can go much further. Think about the Apollo program. They didn't shoot off a guy to the moon in the first place. First, up and down. Then 1 time around the Earth. Then meet 2 vessels and see whether it works. Then make satellites for communication. And then go to the moon, but don't land, just go back to see whether that works. And then land on the moon. Because if you want to do it all at once, you're bound to fail. Modular thinking. That is what we need, and I think we can do it. And modular thinking with maximum involvement of the patients. My friend Henning Sundergaard, who I buried last Wednesday, was a big proponent of modular thinking, patient-driven innovation, and so on. And thanks to the invitation from Jenny Flythe, We wrote 2 articles about this approach. And the latest one is in the American Journal of Kidney Disease. I will make sure that it will be on the web page, the Dropbox, that you can read it. There's the details. Anyhow, if this would be the only worry of a non-transplanted and technology-driven approach, well, then I'd be happy if the scan says, hey, wait a minute, you have to, what's that in your belly? Oh, that's just my artificial kidney. We can live with that risk, okay? Of course, transplantation is super the best that we have at the moment. But not all patients can be transplanted, and we shouldn't leave the ones that cannot be transplanted in the dark. So my idea about the future, I'm a technologist, so I'm technology biased, would be that we implant this and that we have wireless communication to the doctors to sit and wait for meaningful events to happen. The data would be coming in. You don't have to go that much to the clinic if you have an intelligent artificial kidney that shows how the values are. And long before you get into trouble, would also signal, we might need to look upon this or look upon that, okay? Now, I heard also about the plastics and the discussion. I can't avoid to say quickly, on the Dropbox will also be lists of actual plastics that are on sale now, medically certified, that are up to a certain point sustainable. And I added many companies, so nobody can say, and I don't know if shares in this. I just want to show there are solutions already now, and they are medically certified. And there's an overview for the manufacturers, what can we use for what. And this is one example I couldn't resist to go a little bit in detail. These are castor nuts. So castor nuts are typically grown, many are grown in India, on super poor soil. Soil that is not really suitable for other food production. So they don't displace other food production, and they are profitable for the farmers, which is important. Why would I grow something if it's not profitable? And the beans are crushed to make oil, and the cake, which is the remaining stuff where the oil is pressed out, can be sold as fertilizer, which is also good. Castor bean. Interesting. And so this is for the farmers profitable, whereas it can go up to 98% of sustainable plastic, medically certified. Why don't we use it? Okay, I'm sorry for the time.
Wonderful. Thank you very much. We heard some really good examples of both short-term and long-term. So we have about 5 minutes for questions to stay on time. Front row, please.
Thank you very much for all the presentations. My question is actually regarding the low and middle income countries. We noticed that a lot of equipment come from multinationals, and some of them are obsolete. Some of our people in diaspora put these things together to send back to our countries, meaning to help. And it's obvious that it's not really helping. It's kind of dumping what is obsolete on us. So my question is, how do we get to stop them from doing this? It's sort of a cry for help. Thank you.
Thank you, Ifeoma, for this excellent contribution. Absolutely, it is a real challenge, if you can say that, in the continent. Because, as you know, we have many humanitarian action from high-level income countries to low-middle-income countries. And yesterday, I was discussing a colleague and says that if you imagine 90% of the machine sending from developing country to developed country is not functioning in our country. Even in Senegal, I have this experience, and usually it will be some waste very difficult to destroy. And sometimes you have another problem about green nephrology is how to do with the non-functioning machine in Europe and sending to Africa. Thank you.
May I add something here? Because this problem indeed is a super important problem. And a few years ago, I was in Malaysia giving a lecture about the standards for peritoneal dialysis. And they told me they were working on their own wearable PD machine. So that was fun. And I gave them some advice on the standards and so on, and that worked. And then they dragged me along to their Minister of Economics, not health. And he asked, is this something they can pull off here in our country? And I had looked upon the diagrams and the ideas and the designs. I said, yes, they will be able to produce this machine in your country with the resources you have here. I'm convinced. It'll take some investment. But if you manage to pull that off, you're not removing money from your economy to buy stuff abroad and keep buying stuff abroad and and the money is pumped out of your economy. You'll never see it again. But if you make your own machine, you're creating high quality jobs, you are reliable with your own industry, and the money stays in your economy. And guess what? So they did. That was super nice. And in the article that was sent to HAKD, this machine is even on the photo in display. It's in clinical trials. It's working on humans. So I hope that it would be super duper if Malaysia not only would use that machine for their own patients, but even be able to export it or transfer the recipe for local manufacturing, that would be even better, to other countries. It can be done, and it's a great question.
And this is actually a very important point that you bring up in terms of the economic minister who was the first person to see this. The same thing happens in many countries, so it's important, again, to think about that business plan. The Office of Management and Budget, OMB, in the United States is definitely the first group that sees any proposal to cost it out, whether it's cost neutral or not.
Caroline.
Yeah, great. So I mentioned earlier about Green K, and I just wanted to reflect on all these innovations and challenges in bringing potential innovations to market. So I'm very privileged to be co-chair on the Procurement Industry and Innovation Working Group. My colleague in this work, Surin Kanaga-Sundaram, unfortunately couldn't be here, but speaking for both of us, we're looking to unite our global community of potential procurers. We want better goods and services, and we recognize that there's a so-called mountain of risk for industry. At what stage did they scale up? They're nervous because they don't have a market. We are frustrated because we don't have something to buy. So we're trying to bring everybody together, unified voice here. We're looking to develop communities of practice for clinical people to support potentially vanguard procurement exercises, looking for lower middle income country settings as well as higher income settings for that. So we'd welcome any conversations. And I think if people want more information on that, please reach out to us. So I'll just quickly mention the email procurement@theisn.org. We've got a dedicated site there, and as well, you could reach out to your regional representative for that. So hoping to bring everybody together. I'll mention as well, we're looking at a separate community of practice with industry. So we're hoping to have some privileged discussions to bring back what the clinical community wants, so we can direct where industry can focus their attention.
Wonderful. Dan, one more?
I was just going to say these are all critical points that you bring up, and anything about procurement, again, think about the global policies or regional policies that will make a difference to make it a smoother stream, find the champion within the organization.
So I want to thank everyone on the panel. That was a fantastic way to close the morning. I think it gave us a lot to think about for this afternoon. So we are going to break for lunch. Lunch is in the Zurich room, which is just down the hall. We will be there for an hour, so 12:15 to 1:15. And then this afternoon, we're going to go straight into the breakout sessions. So you've been assigned to one of 3 breakout sessions. The rooms are Madrid, Paris, and London, and those are kind of across the hall on the other side. We ask you to be in your breakout rooms ready to talk at 1:15. So enjoy your lunch and then be on time for this afternoon. We'll see you later.
May I make one last remark? I can't resist. If the motto of your president, imagine, it would be drill, baby, drill, just imagining, then realize that drill would be for money, drill for money. So don't come with the arguments primarily, save the environment. No. Why are you throwing away good money? That is the argument that will be listened to.